This presentation this is our first webinar for the coalition from Central Appalachian states that represents our effort in hepatitis C. It's convened by the Community Liver Alliance and Susanna Alliance, and has given us tremendous support and guidance in this coalition together. So our presentation today, the members, I should say, the member states from the Central Appalachian region are West Virginia, Ohio, Pennsylvania, Kentucky, and Tennessee. And our first presentation comes from the Department of Public Health in Kentucky, and it's titled "The Screening Pregnant Women for Hepatitis C in Kentucky, Legislative Advocacy and Action." And we will hear from Kathy Sanders, and Amanda Wilburn. Each of them will do a 15-minute presentation, and then the last 30 minutes will be for questions and answers. And the participants will be muted until it's time for Q&A. And you can share your questions with us using the chat box on this at the bottom of your screen. And I'm delighted to have you with us. We hope this will be very informative. So Kathy, please feel welcome to begin.
Okay. Well, good afternoon, everyone. I've got my colleague here, Amanda Wilburn, and we're just very excited to have this opportunity to be able to talk about the great work happening here in Kentucky in regards to hepatitis C. And I'm going to start out here by, Amanda's heard me say this before, but you know, up until for the last 5 years, the adult viral hepatitis team here in Kentucky, we were a team of 2. And last August, and that was myself and Dr. Robert Brawley, and last August we were able to apply for a grant, and very thankful that Amanda Wilburn was able to join the team. Unfortunately, in June, Dr. Robert Brawley is no longer with the Kentucky Department of Public Health, so we're back to, this is it, tag, we're it, a program of 2. And so despite the many challenges and obstacles that we're facing here in Kentucky related to, you know, hepatitis C and advocacy and working, as you know, that we are in the middle of a tremendous epidemic throughout this whole Appalachian region. And it certainly is an impact that it affects many families, and what our concern is generations of children being exposed to the virus. And so before I go any further, let me make a comment. And every year I choose a word, okay? And last year it was press on, and so this year I actually chose 2 words, and I wasn't really sure if late December if this was going to be my word or not. But when I went to church the first Sunday in January, the scripture was about Nehemiah. In Nehemiah, he says, he's quoted as saying in Nehemiah 6, "Why should I come down? Because I'm doing such great work up here." So my word for the year was mountain mover. And certainly this year, our program has been able to move a lot of mountains. We're continuing. And so we're not really coming down. We're still up here and we're doing great work. So with that being said, thank you for allowing us to share what we're doing here in Kentucky. And so, unfortunately, Amanda and myself, neither one have any financial relationships with commercial interests to disclose. That would certainly be helpful to us. So we're going to start out with the background. We're going to talk about methods, results, and then we'll just do some discussion. And keep in mind, we're going to tag team this. So at any point, Amanda may just jump in, and I may jump in with her because we are a team. So just real quick here, we know hepatitis C is a silent epidemic. Approximately 3.5 million persons are living with chronic hep C in the United States. We know that applying these data to Kentucky, there's about 53,000 Kentuckians that could be living with chronic hepatitis C infection. Many do not know it, as you know. But the actual estimates could be, some people really feel like that it could be 14 times the number of reported acute cases. So we know that according to what we've been able to do here, that our work in the hepatitis C is much more prevalent than the 53,000 Kentuckians. So when you look at incidence of acute hep C in persons of 20 to 29 years of age in Kentucky, Tennessee, Virginia, and West Virginia, what you can see is traditionally, you would look at urban and non-urban areas. And what you can see here is the urban areas is where we're seeing the greatest impact of hepatitis C versus, well, the non-urban areas, as you can see on this graph here from 2012, as the rates continue to climb. So let me give you a quick background here. I started this position in early 2013. And prior to me taking this position, there were some carryover monies because my position had been vacant from the CDC grant. And so there was an initiative where 13 local health departments throughout, well, actually all the local health departments were contacted. The 13 local health departments agreed to start hepatitis C antibody testing, and we always did the RNA confirmatory testing in our state lab. But we started out testing in a pilot project in STD clinics throughout Kentucky. And so as we began this project, keep in mind that that was when the CDC had come out with the recommendation for baby boomers to be tested, and also here in Kentucky, House Bill 1 was passed, where it became more difficult. We had a CASPR law. It became difficult for individuals who were being prescribed opiates to get those because they were now being regulated more closely. And so what happened concurrently were individuals, and so what happened at that point is individuals who could not get opiates very quickly turned to other street drugs, and that was heroin became one of those drugs. At that point, we were hearing reports of construction crews, leaders giving the individuals or their employees heroin just to keep them motivated and keep them to be able to continue to work on the job. So as we began to see the results and look at the results of the tests that were coming in, we did over 9,000 tests, and lo and behold, we had a very large number of individuals hep C positive in the 18 to 35 years of age. And so my background has always been children, women's health, and so I was immediately concerned about the mother-to-child ratio because as we look at this 18 to 35 years of age group, this is women of childbearing age. And at that point, I was far enough into the program and far enough into my position to say, we're not getting any money. Why is hepatitis C not being able to leverage like HIV and other programs? Why don't we have the money to address this issue? And so when I went to my boss, Dr. Brawley, and I discussed, okay, this is women of childbearing age. At that point, he said, let's do a pilot testing project for 3 months. Now, also at that time, and as you know, it's still this way today, we do not have a whole lot of data about that mother-to-child transmission. When you look at the research that's been done, most of that research is late 90s, early 2000s, but never at a time in history have we had the number of young, healthy women that are in acute infection with hepatitis C because of injection drug use. And so, is it the higher the viral load, the greater risk of transmission to these infants? So we wanted to look at it, we wanted to get an idea, and so we began a voluntary reporting project in, let's see, do we need the next slide? Okay, so yes. So in late December, actually early January 2014, we sent out information via ACOG or Kentucky, to OBGYNs in Kentucky, as well as my newsletter, that we were going to do a 3-month voluntary reporting project for them to report all pregnant women with Hep C in Kentucky, all infants born to these mothers with Hep C infection, as well as all children age 5 and under with Hep C infection. And as you can see here, we talked about how that the reports were more than we could process, meaning the reports were coming in. There was only myself and Dr. Brawley. We were not able to successfully enter as quickly as we would have liked that information into a database that we had. We were actually able to get other programs to donate some of their staff to assist with the data entry, but this project was a very low priority for them. So as we continued on, within the first 3 months, we knew very quickly that we needed to continue this project because of the amount of reports that were faxed in. And so we continued with the project, and in February of 2015, it became mandated by law for all women with Hep C, all infants born to mothers with Hep C, and then all children age 5 and under to be reported in the state of Kentucky. So what I have here is a copy of the EPID 394 form, and this was revised in 16, I believe. Our initial form, we had some issues, and you learn, and so as we began initially reporting, the form wasn't exactly as we wanted, such as one of the things was, we had a question, does the mother injection drug use? Or we had yes or no, but we didn't have an unknown. And so was it blank? Was it because it was unknown? Or was it blank because so anyhow, so we had to revise it. So this is a copy of the EPID 394 form. We would gladly share it with you if you're interested. And so this is just a bar graph to show you the number of reports from December 2013 through June 15 prior to this becoming mandated reporting. And you can see we were getting anywhere between 30 to 60 reports per month. And once again, keep in mind at that point, not all pregnant women were being tested in Kentucky. So as I said earlier, in law, it says Kentucky law in February 2015 mandated, but it really didn't become in effect until July 2015. And so we were able to successfully have this reporting requirement implemented during that time. So this is just to give you an idea of the number of reports that we received of pregnant women, 1,651, and then of pregnant women in Kentucky during this time frame, a 2-year time frame, and then children, 757 children born to mothers during that time. So I put this map here to show you that this is where our acute Hep C cases are. From 2011 to 2015, you can see the highlighted, and this is the whole Appalachian region. It's also, when you look down that northern Kentucky, all the way down that Cumberland Valley, there's like a line, and that's the 75 corridor that goes down through there. And so right of that is Appalachian Kentucky, and that's where we're seeing the highest acute cases. But what you're also going to see is when and later on, Amanda will show a map here, this is identical to the number of where our perinatal reports are being shown as well. And so when you look at Dr. John Brooks' studies, I'm sure many of you all are familiar with his study where he identified 220 top U.S. counties throughout the country that were at risk for a similar outbreak of HIV, Hep C, such as Scott County, Indiana. 54 of those high-risk counties are in Kentucky. Actually, out of the top 15, 13 were in Kentucky. And when you look at the map, you can see once again that whole Appalachian area is an area where not only we're at risk for HIV, Hep C, according to Dr. John Brooks' studies, but that's where our acute cases are, as well as that is where our perinatal reports are seem to be most evident. As a matter of fact, quickly here, let me go back, I'll just show that. There are, at the bottom of the map, you'll see like Leslie and Harlan, you'll see some counties. There's 4 counties in this area, and 3-year period that there were over almost 400 infants during that time born to mothers in that area, and the mothers were reported with Hep C. And so, with that being said, these are very small counties, populations of about 26,000. So, you know, our perinatal Hep C project has always been a very high priority for us at the Kentucky Department of Public Health.
Okay, I'm going to pick up for just a minute now and talk to you a little bit about the data. Like Kathy said, even with the mandate going into effect in 2015, they didn't really have anyone on staff to look closely at the data. We were lucky enough to bring on contract personnel at the beginning of this year that finally got us, or at least is working to get us caught up on all of that data entry. And we were able to put some information together and actually talk about it at CSTE this summer. So I'm going to share just a little bit of that with you. Like Kathy mentioned, our Kentucky map, pretty much every Kentucky disease burden map of any kind of looks like this, with southeastern Kentucky being hit the hardest. You can see here, when we look at our rate of Hep C infection among pregnant and postpartum women per 1,000 live births, the exact area Kathy was just talking about, Harlan County right here at the very bottom right corner, they had a rate of 71.7 per 1,000 live births. So that kind of gives you an idea of what that area is facing. But what this map also tells people who are familiar with Kentucky counties and the opioid crisis and how it's affecting these communities is it's starting to show you where underreporting is likely happening. In the Brooks study from CDC that Kathy was discussing, the #1 county in the nation was Wolfe County, Kentucky, which is right here, this light blue in the middle. So they were ranked #1 in the nation of 220 counties. So you know that they have a problem, yet we didn't receive a single report from them. So getting into the data and being able to map some of this and look at it more closely, we're going to be able to target where underreporting is happening. Fortunately, we have another source of data we can compare to. Our Office of Vital Statistics has provided us birth certificates that report a history of hepatitis C of the mother for several years now. So that's, you know, it's not exactly, you know, an exact comparison, but it's not apples and oranges either. So it kind of gives us a good idea of where we can look for gaps. And when we looked at that from 2014 to 2017, we compared the reports coming in the Kentucky Viral Hepatitis Prevention Program to those reporting hepatitis C on the birth certificate. And even after the mandate in 2015, you can see that the gap is still significant. Again, you know, we're gonna have to do some work to match with that birth data to see exactly who we're missing and where, but that's something that we're gonna get to because clearly we have an underreporting problem. A few years ago, CDC, KDPH, and Quest Labs collaborated on a project looking at hepatitis C virus detection in women of childbearing age and potential risk for vertical transmission in Kentucky. And the results indicated that among women of childbearing age, Kentucky had an increase of 213% from 275 to 862 per 100,000. Where HCV RNA was available, there was an 80% positivity rate showing current disease. Again, there are multiple risk factors associated with pregnant women and mothers with HCV in Kentucky. Predominantly, this is our injection drug use and opioid epidemic problem. Clearly, we have vertical transmission of HCV occurring, which, you know, Kathy already showed you some of the numbers for children that we have, and I'll share a few more. And again, this isn't typical where you may see in other states. Our problem is in our rural Appalachian areas and as well as our urban centers, but it's really concentrated in our rural areas. So we pulled out some risk factors for mothers and pregnant women that were reported to our program. So this isn't the information from the birth certificate, but the reports that we're receiving in our program. And not surprisingly, the biggest risk factor was intravenous drug use, with 35.9% reporting having that risk factor. Multiple sex partners was significant as well, 8.7%. and then they start to decline there. So clearly, injection drug use is our big problem. The age group of mothers and pregnant women being reported kind of reflects the birth rate in general for those age groups. But you can look at our children, and under 12 months is 87.2%, and over a year old, those reporting is 12.8%. So since we're just kind of ramping up surveillance efforts, we have lots of things that we look forward to doing. We have lots of information that has come in that was not on that EPID 394 that Kathy shared with you. Some people have sent in Excel spreadsheets with just a line list of their positive cases. So we're still working on working through entering that data that's been submitted atypically. We want to look at additional risk factors for children and break that out a little more. We want to look at our positives and then see what, if they had a positive mother, what that exposure looks like. And we want to work with our Division of Maternal and Child Health and collect their Neonatal Abstinence Syndrome data. They have a pretty robust surveillance system for that, and do some comparisons to see if these exposed babies are the same babies that are NAS babies. And then one of our partners at a large university medical center who treats these children, she has seen a rate of 40% of children born to HCV-positive mothers going into foster care. So we want to look at that guardianship as a risk factor as well. Like I mentioned before, we want to match our data set with the Office of Vital Statistics birth file to identify the true gap in reporting. And then when the screening, after the screening regulation that Kathy's going to discuss next, we want to look and see if people are actually complying with that screening regulation. So that's some things that we have to look forward to.
Okay, back to me for a second or two. So one of the things that I just want to kind of move forward and give you an idea as to how we were able to move forward with this past April, our governor signing off on a requirement for all pregnant, not a requirement, but Senate Bill 250 being amended to include all pregnant women. And so how did we do this? Well, for 3 years, we worked very closely with the Kentucky Department of Public Health legislative team. First off, we did the mandatory, and then we did the required reporting of all pregnant women. And then the second was we mandated reporting. And then the third was the second was we revised the form. And so, one of the things, let me interject here, when Amanda was talking about 35% injection drug user reporting of these pregnant women with Hep C, many of the forms initially were not completed. And so we know that it's much higher. And so that's one of the reasons why we did a revision of that form, so that way we would know that yes, no, or unknown. And so, we amended that form. And so it just was logical after review of the amount of reports that we were seeing that the next step would be for all pregnant women in Kentucky to be tested, because we recognize that it's just the tip of the iceberg, the reports that we're receiving. And it's also imperative, to be honest with you, in Kentucky and most states, only acute is reportable. And there's such criteria that it's really hard to really get a good grasp on what are we seeing? What is this epidemic? And so when we can just take a sample of pregnant women, we know that how many more women are out there that and individuals with hepatitis C. I will tell you, I go to the blood centers a lot, and they will tell me you cannot imagine the number of young women, young college-age girls coming in here with Hep C. So with all that information, we knew that it was just imperative for us to move forward. We know that there are women, and it'll be interesting next July. We would love to come back and share the data as to how many reports we've received and how many reports that we estimate we probably might not have received because many women are not maybe being identified or tested. So it takes a village. So, we have been able to very successfully partner. Early on, when I started this position, Dr. Brawley said, go out and talk to people. And so, hey, that's what I'm good at. So I went out, met with the people at University of Louisville, Dr. Claudia Espinoza, Michelle Rose from Norton's Healthcare. We work very closely with the University of Kentucky. We have been able to strategically partner with stakeholders throughout the Commonwealth that we all have one interest in. Barbara Kay from U of L, we have one interest, and that is addressing this hepatitis C in Kentucky. And so it takes a village, and so we've been able to partner. And so that was very instrumental in us moving forward. So in late fall of 2017, up until that point, we had been working with, as I said earlier, a legislative team, but unfortunately we had some people that were working with us and they left those positions. And so there were some changes in the Kentucky Department of Public Health Administration and leadership team. So we were hitting a time frame in late October where we knew that we were going to run out of time. So at that point, we quickly reached out to our partners at Norton's Healthcare. And within, 2 days, Michelle Rose and her team came back to me from Norton's and said, we will do it. We've got the attorneys and they're willing to work with us. So we at Kentucky Department of Public Health, we gave the guidance and verbiage for this legislation. The legal team at Norton's Healthcare, which is a nonprofit, they took the lead and they presented the addendum to the legislative committees in order to present and move forward with Hep C testing in pregnant women. And once again, we could not have done this without Michelle Rose from Norton's and Dr. Claudia Espinoza. She is doing great work at University of Louisville. She is testing all children in the Neonatal Abstinence Syndrome, NAS at U of L that are being diagnosed with that. And so she is doing a lot of research in vertical transmission as well. So in April of 2018, SB 250 was amended, and as I said earlier, all pregnant women are being tested in Kentucky, and it is recommended that all children born to these mothers be tested as well. So factors significant in bringing about this change: past meetings and collaborations with identified stakeholders throughout the Kentucky imperative. Know who your partners are, know who can help you move forward, creating awareness, prevention, and any type of educational activities that you need. Relationships. So as I said earlier, that may be the best thing I'm good at is relationships. I'm not the smartest person in the room. I'm not the best speaker, but I'm really good at relationships with people. I can pull up my cell phone right here, and I probably have just about everybody's number in my cell phone that I can reach out and say, hey, what about this bill? Or, hey, tell me about Hep C. What are you doing? Or can you be here or there? And so I can meet with them. They presented our conferences. We have one of the best conferences, I think, throughout the nation. We just had our 5th annual conference, and people are like, wow, we had over 350 individuals engaged. We have key stakeholders with the common interest of elimination, and the room is on fire. And it's not a room filled with people that are on their computers or laptops. It's people that are truly engaged, truly interested in making a difference and getting this to the front. Because as you know, we're not to the front. We're not a priority. And so how do you do that? You continue to just be at meeting after meeting. You continue to bring your stacks of information, say, this is pregnant women, this is hepatitis C, what are we doing about it? Because if we don't do something about it now, we will later. So this is a copy of the revision of SB 250, which once again, this walks through when it was introduced to the Senate in March, to then to the health and welfare reform in March 5th that moved pretty quickly. There were not a lot of questions. Most people, a lot of people were behind this because, our data speaks for itself. It just seems logical that we would move forward with testing of all pregnant women. And so, once again, became effective July 1st, which is KRS 21416 to establish all pregnant women be tested for Hep C and recommend testing for children born from a pregnant woman who has a positive hepatitis C test. Now, you know what? this is all a step process. So we recognize that now that we're testing all pregnant women, the next step will be we need to look at what our numbers are and get a better idea. And it could be that the next thing is we do something with children born from a pregnant woman. It may be that depending upon our numbers, we may even, I'm not sure what we could do, but some of my thoughts are, we just had our camp, Kentucky Hepatitis Academic Mentorship Program. I'll talk about that in a minute, but a pediatrician stood up and she said, what are we doing about all these pregnant women in my region? They're giving birth. What about these infants? And she said, I think I'm just going to start testing them all at the 2-year when we do the lead screen. And there are some things that we're working on. We know that OraSure is working with some people here in Kentucky, and they're trying to, because the OraSure, the rapid, is only FDA approved for individuals 18 and over. And the only reason why they did that is simply because when they were going through the FDA approval process, they never in a million years imagined that they would be testing children for Hep C, or that we would have this vertical transmission issue. So moving forward, what we've got here is just a sample of screening guidance that we have for our local health departments for screening pregnant women. And then you will see here in each pregnancy as well. And then this is screening and referral guidance for infants born to mothers with Hep C. And so feel free to, use this as a resource if you're interested, but this is what we're doing here in Kentucky. Updates. We most recently had our 5th annual viral hepatitis conference, as I said. We had over 350 individuals in attendance, and it's a great day. It's just an unbelievable day where there's a lot of enthusiasm. And then this year was our first year for the Kentucky Hepatitis Academic Mentorship Program, which is called CAMP. And it's logical that we continue to move forward. We've talked about this whole Appalachia region. We've looked at the number of hepatitis C rates in the perinatal and the acute in that area. And so what was missing? What was missing is the number of providers in that area. And so in late October 2017, our Medicaid program, thank the Lord, Dr. Liu and his team, we worked very closely with them. They were able to remove the barriers for Hep C treatment, and that included the barrier for addiction. The substance abuse was removed. So, in the past they had to be clean for 6 months. That was removed, as well as the fibrosis score was removed. At one point it was up to a 3. And so when that happened, the only thing that remained in place was the consultation with infectious disease provider. And so with our camp, we have been able to successfully create a program where primary care providers can take our camp training, and then they are linked to infectious disease physicians, so that consultation piece is fulfilled. And so this is a copy of the guidance. So be happy, we're not here to talk about the camp, so I'll move forward, but this is the guidance that we put in there. It's imperative once a woman is positive that even her past pregnancies of those children, that they be tested as well, and so we have that in the guidance. This is the infants born to mothers screening for camp as well that we put together. And you want to talk about the consultation form? This is the copy of the consultation form, and we are so excited about this form. So
sure. So this is the form that the primary care provider will complete and then send to a specialist that's part of our camp faculty for their review and consultation. And then once that review has been completed, the specialist will advise the primary care provider on how to move forward with treatment, and that will satisfy the Medicaid requirement for the consulting with the specialist piece. And this form has actually been approved by our Medicaid fee-for-service already, and is in jury with our MCOs currently. So that's exciting for us. It's exciting for the primary care providers who have wanted to treat their patients who come in with Hep C but haven't been able to treat them, and who know that their patient isn't going to drive 2 to 3 hours to Lexington or Louisville to see a specialist and get treatment. So we're very excited, and we think that this form is a great streamlined way to bridge that gap.
And so you'll notice we've got on there is if a female pregnant and postpartum 6 months, because we want to target these women, and after they deliver postpartum, we want to get them in. We want to start treatment in these primary, especially in this Appalachia or throughout the state. We want these women treated so that way, because we know from our data they are having additional pregnancies, and so if we can stop that vertical transmission, that would be fabulous. So that is a high priority for us. And we would like to thank Dr. Robert Brawley. He was the brainchild behind this program, and so we are very thankful. Raven Simmons, she is the one who's done all our data entry, which is a huge, as we continue to get reports day after day now that it's mandatory. And once again, Michelle Rose and Dr. Espinosa from Norton's and U of L, they are just our stakeholders, and they are partners with us, and we work very closely with them. So we'd be happy for any questions that you might have.
Well, thank you both very much. That was incredibly informative and interesting, and clearly the epidemic of hepatitis C is shared by all of the states that are represented in this hepatitis C coalition, including large proportions of women of childbearing age who have chronic hepatitis C. So I'd like to open it up now for questions from the participants. Is there, let's see, let's look at the chat. Were there any, doesn't look to me like any questions were submitted through the chat line. Is that correct, Susan?
Yes, we don't have any questions yet.
Okay, well, let me ask some, and then this may spur some other questions from the field. So what do you think was the most influential information and data that convinced Kentucky legislators that passing a legislation to test pregnant women was the right thing to do? What do you think? Because it didn't seem like there was much opposition, right? It seemed like the votes went almost unanimously in favor. So, Amanda, did there need to be, and Kathy, did there need to be, some compelling piece of information that convinced everybody? What's your take on that?
Well, I think that the great work that we've been able to do by our reporting is that, when you look at the data, when you look at our reports, it just it's logical. When you have, even our birth certificate data, when you have over 4,000 women reported with Hep C in a, 2012 to 2016, when you look at that data, I'm inclined to say, how could you not? And so, we had no opposition. Of course, Michelle Rose and her team, and they are, I think, probably not just our perinatal data, which, by the way, I've said this before in other meetings, but, I'm invited to all these other meetings throughout infectious disease, and hepatitis is never, not very often a priority, but I always make it a priority when I go to those meetings, and I've got my stacks of paper, and they might be talking about 20 cases of this, and I'll pull out my stack and I say, okay, do you see this pile here? This is the number of women reported to us since February with Hep C, or the number of infants born, and we don't have staff, we need money, we need resources, but most importantly, we need to continue to move forward in testing these women. So I think that was very instrumental in our data, and if we didn't have that, if we hadn't done this voluntary reporting, I think we would just kind of be stuck in the mud somewhere, still trying to figure out which way to go. But with that data, I think it's just been imperative. But I also think that, I keep mentioning Michelle Rose and her Norton's team, they were doing, they've been doing for 2 years now a Gilead Focus grant. And so they've been able in their EMR to implement hepatitis C testing in their primary care settings. And so they've done over 90,000 tests. And so when you look at their data as well, and the number of women of childbearing age that were screened, and I don't have those rates right here at the top of my head. At one point I did, but then when you look at the number of not only positives, but the number of pregnant women out of that positive group, it's just enormous. And so it's something that you can't ignore once you have the data. And so we were able, most of these legislators are also dealing with, and they understand this injection drug use, this opiate abuse in their communities. And so they're seeing the numbers of the individuals that are, overdosing and, just the impact that this is having. And so, I think it was presented in a way that we've got to screen these women, because if we don't, 10 to 12% vertical transmission rate. I mean, like when you look at, earlier I mentioned from 2014, I think, to 2017, those 4 counties with over 400 infants born to mothers with Hep C. Well, that's 10%, that's 40 infants in that area. And so I think that we've just been able to get into some people's ears, and I just think that was imperative in convincing legislation that this was the way to go. Do you have any comments?
No, I agree with what Kathy said. I mean, having good data available to share with people is going to be your biggest thing. But also, like she said, in Kentucky, I think we've done several things legislatively that I've lived here my whole life that I thought would never happen. It's because every family and every legislator is touched in some way. I would have never thought that we would have almost 50 operational syringe exchange programs in our state. And it's the same thing. I think that people recognize that something has to be done to combat this opioid epidemic, or at least try to mitigate the bad things that come from it. So I was a little surprised that there was no opposition to the legislation, but I was not surprised that it went through.
Thank you. Let me ask the chronological next question, which is, I realize this only went into effect on July 1st, so it's really early, but in planning for the legislation, and since the legislation passed, what kind of efforts and plans do you have in place to educate the primary care providers and OB-GYN providers about this law? And similarly, what about women of childbearing age? How are we getting information out to them about why this is important?
Well, I think that, let me speak, and then I'll let Amanda chime in, but I think that you just hit the nail on the head when you talk about how do we get this information out here. We've applied for several grants to try to get a perinatal Hep C coordinator, because, we've got to reach out to these pediatricians and these primary care providers. We have a newsletter that goes out. It goes out to over 4,000 individuals, and who knows how many more afford it. It goes in the infection control groups, and but it's hard to get the message out. And let me just tell you a story. Here in Kentucky, we have a Hep A outbreak, and we have over 1,400 cases in the past year, since last August, that have been reported. And just this morning, I got off of a call from someone in Eastern Kentucky, and they have a very large medical center out there, and she said, Kathy, we're getting referrals, GI consults from some of these smaller primary care providers, and they're not testing for Hep A, and these people are Hep A. And so she's like, we got to get the word out there. There's like 40 new cases in the last week. So how do you get the information out there? We're trying through our newsletter. We're doing our conferences. Next step is we would like to get on board to present at the Kentucky Primary Care Association. I presented last year. We'll apply again this year to present. We presented at the Nurse Practitioner Conference. And so it's a matter of getting on the agenda and getting the word out there. And obviously, if the more staff that we can have on board, the greater impact that we'll have. And so it would be ideal for us to be able to have funding for a perinatal person that could do exactly what we're talking about doing, except focus on the perinatal.
Do you think that, have you created, or are you thinking of creating a specific website to, one to educate the public, and maybe one healthcare providers, so that there's an easy way they can look this up?
Is the Kentucky Hepatitis Academic Mentorship Program. which we've partnered with the Kentucky Rural Health Association. And so all of our camp materials are on this Kentucky Rural Health Association. And so moving forward, what we're doing is, and Amanda showed you the form that we have for the consultation, but we're looking at developing a registry, which would include having a website developed. So that would be consultation, that would be referral, but there will also be an educational component for primary care providers, for pediatricians, for ER physicians. We had ER physicians that attended our camp, as well as surgeons. We think that probably last week we got a call that a surgeon was interested in coming to camp because they're wanting to treat, because in their area there's not a GI or infectious disease, and so they're screening these individuals, for during pre-surgery labs, and they're identifying individuals with Hep C with nowhere to refer. They're interested in starting and learning how to provide treatment.
Let me ask
So,
another.
with that being said, with that being said, with the website, there will be a specific site, information site for pregnant women and born mothers with Hep C.
And Judith, we have a question in the chat box.
I saw that, and the question from JT Messerly is, was there any pushback on relaxing the restrictions about who can prescribe Hep C medication from the specialists, from the ID or GI community?
Quite possibly. But we maybe a little, because listen, it's a moneymaker. Okay, when you really think about it, some people, but then I keep saying, okay, there's more. There's a lot of people here, and we're talking about health. We're talking about our citizens. We're talking about, yes, because at the end of the day, offices have to be able to bill, and they have to be able to keep their own doors open. And sure, you know what, the pharma side is huge. They want to be able to prescribe, but I can tell you, we have a group of camp faculty, and they are providers across the state, and they're doing it for free. They're doing this consultation for free. And so, sure, there might be a little pushback, but listen, there are different models out there available, and the bottom line is we have got to be able to provide treatment. And obviously, our University of Kentucky and University of Louisville, they're doing a great job, great people, but sometimes it might be a 6-month wait period just to get somebody in. And not just that, but some of the challenges of that is, you've seen our maps from Appalachia and this eastern Kentucky, and so just traveling, okay, if you have a car, great. If you've got gas money, great to get there. But then, then you got to be able to get in, and then you got to be able to walk in there. And it's just so challenging for so many people that's one of the reasons why this primary care model is we're excited about, being able to bring it in communities where they're able to treat the patient and prescribe. Go ahead. Do you have anything to say?
No, I think we have felt a little bit of pushback and apprehension from some specialists, but I think that outnumbering that is the support that we've gotten from specialists. I think that they see, this is their patient population that they care deeply about, and they're more interested in treating as many people as possible, as easily as possible. So we do see pushback, but overall, it's positive.
And we've been able to get a great group that work with us. Dr. Ballesteri, who works with Cincinnati Children's, he's doing a lot of clinical trials. He works with us, and they volunteer their time to come, work with us and, create these plans, create agendas, and, making the impact that we're having.
Quite frankly, I would just think from my perspective that there's so much hepatitis C in these states that, to the extent that primary care providers actually open access to people, there's still plenty of other people for the specialists to see. I'm waiting for Dr. Valdesari, I think, has a question. I'm waiting for him to type it in so I can read it to you. But while I'm doing that,
Can I make one more comment? One of the things we've been very careful about is anyone with a fibrosis score of 3 and above, they need to go to their GI infectious disease physician anyhow. So that can open up the door for the specialists to, really focus on these individuals that have maybe a little bit more challenges in treatment. But, with the latest drugs that are out there, we all know this. It's a great opportunity. It's a great time in hepatitis C that we can actually have the ability for individuals to get treated in 8 to 12 weeks and be able to be cured of this disease.
Great. I think Dr. Valdesari is still here. It is. He's still working on typing it. So let me ask a question. Who are the physicians, the specialists who are reviewing the camp, those forms that you showed us? Who's doing that, and are you compensating them for their time? Wait a second. Somehow you got muted, you guys. Let me see if I can.
Ronald, if you have a question, you can unmute yourself. You wanted to ask it verbally.
Yeah, I am unmuted now. Thank you so much for that. This is Ron Valdesari. It was a little, as I said to Judith, it's a little complex, so I would rather ask it than type it. So it's very, very clear that you had widespread support from legislators and essentially no pushback. I guess my question is, are you or were you aware of any pushback at the community level, particularly among women themselves, given the association of hepatitis C infection with injection drug use and the stigma that entails? And maybe there was none, but I think it would be interesting to hear from that particular sector if people were supportive. And one of the reasons I ask that question, it gets back to Judith's comment about being able to promote this. You've talked a lot about the legislative and the care provider support that you have for this. Have you been able to mobilize support in other sectors of society that are not directly involved in providing care? That's another way in which I think we can promote this issue. So those two questions are kind of intertwined, and I'd like to hear your comments on them. Thank you.
Well, let me start here because we get asked that question a lot. And here in Kentucky, that we've not had any pushback. As a matter of fact, and the question will come up occasionally, well, would this stop a woman from getting screening or getting her care? And, there's so many other things that they're tested for as well. I mean, they're tested for STDs, they're tested for, the infants, if there's any signs and symptoms of the infant going through withdrawal. They test the infant after they're born. And so I will tell you that the reports that we're receiving, even when it was, because just now, think about it, just now this past July, it just became mandated. So prior to that, they were all voluntary reports that we were seeing. And I can tell you, I can't count how many reports where one showed up and delivered no prenatal care, delivered in the gas station, delivered in the ER, delivered, with twins. And so it's not that for the Hep C that they're not getting prenatal care. Many of them are getting the prenatal care because they show up, they might be tested for something else. So, and they're afraid that their children, that's a priority, that their children may be taken away from them. But, most of our communities are working very closely. There are some pieces of legislation in passed to work with these moms. I mean, you read day after day, people don't want to take these infants from their mothers, although we have over 10,000 infants in foster care here in Kentucky, and it keeps growing because of this epidemic. But I've not heard or seen any pushback from any of the providers that these women aren't going to come in because they're going to be tested C.
Okay. Thank you. And what about the second question about working with other sectors of society, whether that's the business community or the faith community, or to promote these efforts? Because again, it's pretty clear you have strong support on the legislative and medical side, but in terms of disseminating this effort, I'm interested in hearing what is taking place to build a broader coalition.
Well, you know, one of the issues and the challenges is there's only two of us. And so we are working very closely with our partners. And, you know, trust me when I say that most people in the state know us. I mean, we're very well recognized, but there's only so much noise that we can make. There's only so much things we can do. I mean, you know, we were at the, Amanda's going to the Kentucky State Fair on Friday. We were very involved with the World Hepatitis Testing Day, where we tested all over Louisville. We do have faith-based groups that reach out to us. And so I think it is imperative, you know, to get them involved. That's something that in the past, I may have, you know, talked with them, sent them information. I think our newsletter is very informative, and a lot of people really love we have a monthly newsletter that we put out. And I think, you know, we get a lot of positive feedback to the groups that use it, forward it on. But I think that's a great idea, but unfortunately, we're not the HIV program. If we were the HIV program, just think of all the darn good work we could be doing, because they're fully staffed. You know, they had $20 million this past year of carryover money. And if we had 10% of that people, we would be rocking this place, because we would really be making some even a greater impact than what we're making. But it was just us. That's the bottom line.
That's very interesting, and that probably, you know, resources to do that kind of work are probably limited for hepatitis C, you know, in many locales. I have another question for you that, did you get any specific input, positive or negative, from the Kentucky branch of ACOG, the American College of Obstetricians and Gynecologists? You know, they were the first, I think, the first professional organization that really embraced the idea of universal screening for HIV in pregnancy. And to this day, I think OB/GYN providers are still by far and away the people doing the testing for HIV. I don't think it's happening, you know, in the hands of primary care providers or internists just in general. And it was very powerful when ACOG at a national level said, yes, we're embracing this. We're going to, because we know that we can intervene and do something about it, we're going to test all women for HIV. So do you have any sense about the Kentucky side of that? And if they have embraced it, do you know if they're going to take it forward to the national organization?
Fortunately, I haven't been in contact with anyone from ACOG. I know that Dr. White, who is our deputy commissioner, has kind of like been our person that we're to send information to, because I think she was she the past president of ACOG?
She was in ACOG for a long time, and she was helping the Kentucky ACOG chapter disseminate our information throughout their organization. So we didn't really have much input from them on the front end, but they're gonna, she's carrying our information to them now.
Only because if ACOG became a very supportive of this at an organizational level, then other states, especially states where this is really, hepatitis C is really a burgeoning problem among women of childbearing age, other states wouldn't have to look for legislative action to do the screening. It would just become part of the standard of care. And they were terrific at doing this for HIV. I was just wondering about that. Well, as we get close to the close here, and I want to thank you again, that was incredibly valuable and interesting and informative. Do you have any final words of advice for the other states that are part of Central Appalachia here and that are struggling with similar issues? Do you think we should all try to take a legislative approach to this?
Well, I'll start out here and then I'll let Amanda finish up here, but like, you've got to be out there, you've got to be present, and in meetings, I think that it's imperative as you sit there quietly, then have a 1 or 2 sentence like where you can talk about hepatitis C, talk about your numbers, be vocal, be an advocate, be present, be visible. I think that we'd be glad to assist you, but I don't think it would really be very helpful because I think each program, each state has their own, stakeholders and people that you can work with to help move this forward. But just don't give up. I mean, we have the numbers when you look at our data, and I'm sure your state's data that, if you pull it together and present it, that people can only bury their head in the sand for so long. And at that point, we've got to continue to move forward. If we don't, I worry about the children, these infants born to these mothers. I worry about families, and I worry about people that, chronic hepatitis C, liver disease, fibrosis is not anything that's pleasant. And so we're here to make a difference. And so we'd be glad to answer any questions, or you can email us. We'd be glad to work with you, but it's partnerships are the key here.
Well, thank you for that kind offer. I'm sure you're going to get a lot of calls. And I guess what I would say to the audience, in addition to thank you very much for participating, is we're hoping to do subsequent webinars several times a year, maybe every 2 or 3 months. And we would love to have input from all of you about what topics related to hepatitis are important and valuable for this group to share. The whole purpose of this coalition for us to learn from one another. What works in one state in Central Appalachia may very well work in another, and we want to share those best practices. So thank you very much, everyone, for attending. Thank you, Susan Massardis and Community Liver Alliance for hosting this, and we will see you in a few months.